What is going on, wonderful people? Welcome back. If you're a medical or nursing student currently staring down the barrel of a massive pharmacology exam, well, you're in the right place. I know exactly how overwhelming this stuff can feel, which is exactly why I'm here. We're going to bypass the confusion, save you literal hours of studying, and dissect the foundational science of drugs so clearly that you're going to feel completely confident on test day.
Because here at Confused Neurons, our mission is super simple. Learn, understand, remember. We're breaking down complex pharmacology step by step so that even the most overwhelmed neurons in your brain will be firing perfectly. No more rote memorization without actually knowing what it means. We're building a foundation of absolute logic.
So here's our game plan for today's explainer. 1. What is pharmacodynamics? 2. Receptors and signal transduction. 3. Agonists versus antagonists. 4. Dose-response relationships. And finally, 5. We'll wrap up with some active recall exam prep Q&A.
All right, let's jump right into Section 1. What is pharmacodynamics?
Okay, before we even think about specific medications, we absolutely have to separate the two giant pillars of pharmacology. Students mix these up all the time, but I've got a really easy mnemonic that fixes it instantly. Pharmacodynamics is what the drug does to the body. Notice how pharmacodynamics and drug both start with the letter D? It's the study of the biological and physiological effects that happen once a chemical reaches its target. On the flip side, pharmacokinetics is what your body does to the drug. Just think of kinetics as motion, right? Movement. ADME, absorption, distribution, metabolism, and elimination. So if you swallow a blood pressure pill, the process of it traveling into your gut and absorbing into your bloodstream, well, that's kinetics. But the mechanism of that drug actually relaxing your blood vessels and lowering your pressure, that is pharmacodynamics.
Moving on to Section 2, Receptors and Signal Transduction.
To really understand how these changes happen, we have to zoom way in, from the whole body down to the microscopic level. Most drugs actually exert their effects by interacting with these specialized target macromolecules sitting right there on the cell membrane. We call these receptors. Drugs act as chemical signals just floating through your bloodstream, and the receptors, they act as the signal detectors waiting on the surface. Think of it exactly like a lock and a key. The drug is the key, and the receptor is the specific lock. When the right key finds the right lock and binds to it, boom, a function is triggered inside the cell.
And that lock and key interaction sets off a totally fascinating, incredibly crucial chain of events called signal transduction. Step 1. The drug, which we also call the ligand, binds to the receptor. Now, an unoccupied receptor is completely silent. It's not doing anything. But once that chemical binds, Step 2 kicks in. The receptor activates. It literally changes its physical shape and its chemical properties. This shift triggers Step 3, the absolute heart of the system, the second messenger cascade. It's like a relay race where a baton is passed across the membrane to cellular effectors inside, usually enzymes or ion channels. This step is huge because of amplification. Just a single drug molecule binding on the outside can activate an enzyme that spits out thousands of second messenger molecules on the inside, creating this massive, cascading wave of activity. Finally, this wave culminates in Step 4, the biologic response. Because of that insane amplification, just a tiny milligram of medication can cause your heart rate to drop, your pain to completely vanish, or your restricted airways to pop wide open.
All right, Section 3, Agonists versus Antagonists.
Let's talk about the specific types of keys that interact with these locks. An agonist is a drug that mimics your body's own natural ligands. First up, we have the full agonist. When it binds, it gives you a 100% maximal biologic response. We say it has an intrinsic activity of exactly 1. It maximizes that receptor's absolute potential. Next is the partial agonist. It binds to the exact same lock, but it's just not quite a perfect fit. It only gets you part of the way there, giving you a diminished submaximal response. So its intrinsic activity is greater than 0, but less than 1. And then there's the inverse agonist. If a full agonist turns the volume dial up to +1, an inverse agonist turns the dial down to -1. It stabilizes the receptor in an inactive state and literally causes the exact opposite physiological effect of the full agonist.
Okay, pay very close attention here because this is one of the most frequently tested topics in all of pharmacology. A lot of students fall into this trap of thinking that an antagonist will do the opposite of an agonist. That is completely false. An antagonist simply binds to the receptor, blocks it, and produces a net intrinsic activity of 0. It just prevents the agonist from binding. It doesn't actually do anything itself. For example, if a sympathetic beta agonist naturally raises your heart rate, giving a patient a beta antagonist, like a beta blocker, doesn't actively force the heart rate down. It just blocks the sympathetic receptor. You get a baseline effective 0 from that receptor, which then naturally allows your parasympathetic rest and digest system to take over and lower the heart rate for you.
A really great way to remember this is to think of antagonists as the nightclub bouncers of the cell. They have a really high affinity for the doorway. They stand right there, taking up space, but they have absolutely zero intrinsic activity. They do not dance and they do not join the party. They simply block anyone else, like the agonists, from getting inside and starting the music. If you want to pass your exams, always remember this rule. Antagonists equal blockers.
Section 4. Dose-response relationships.
When we're evaluating how clinically useful a drug actually is, efficacy is the absolute king. Efficacy is the maximal response, or Emax, that a drug can produce regardless of the dose. It depends entirely on the number of drug-receptor complexes formed and the intrinsic activity of the drug itself. A really common mistake is confusing this with potency. Just think of it this way. Efficacy is the ultimate ceiling of the drug's effect. Potency is just how much weight or how large of a dose you need to lift to hit that ceiling. Clinically speaking, efficacy is drastically more important. If a drug ceiling is just too low to give a patient the maximal pain relief they desperately need, it truly doesn't matter how potent it is. You always want the drug that actually gets the required job done.
Let's wrap things up with Section 5, Exam Prep Q&A. Time to see what's stuck. Let's put this theory to the test with a high-yield clinical scenario. A patient in severe pain takes aspirin but gets no relief whatsoever. They are then given oxycodone and the pain completely vanishes. Why does this happen? Take a second and think about those concepts of efficacy and potency we literally just discussed.
So the answer completely revolves around efficacy. Oxycodone simply has a much greater maximal response, a significantly higher Emax ceiling. Aspirin is an NSAID, right? Its ceiling for pain relief is inherently lower. It simply cannot reach that level of maximal analgesic effect, even if you gave the patient a massive, highly toxic dose. Drugs with a greater maximal response are more efficacious. And that is exactly why the oxycodone effectively banishes the pain when the aspirin completely failed.
Okay, let's hit the next scenario. What happens to the biological response if a high concentration of a partial agonist is given alongside a full agonist? Try to visualize the cell membrane in your mind. See the receptors. You've got full agonists and partial agonists all fighting for the exact same spots. What actually happens to the total physiological response? Well, when a full agonist is all alone in the system, it happily occupies the available receptors and gives you that beautiful 100% Emax. But if you add a high concentration of a partial agonist to the mix, it starts stealing those parking spots. The partial agonist displaces the full agonist from the receptors, and because the partial agonist inherently has a lower intrinsic activity, the overall biological response actually goes down. The partial agonist essentially acts like a blocker, an antagonist, in this specific competitive scenario, diminishing the overall receptor response. This competitive displacement is a classic, really deeply conceptual trick question that you'll definitely see on your medical boards.
All right, final question, tying all this foundational theory directly back to saving lives in the clinic. Memantine protects patients from neurodegenerative apoptosis, or programmed cell death, in conditions like Alzheimer's disease. So what is its precise mechanism of action? How does it actually interact with the receptor to stop neurons from dying? The answer is that memantine is an NMDA receptor antagonist. Think back to our rule from earlier. Antagonist equals the bouncer. It equals the blocker. In neurodegenerative states, there is this massive overstimulation of glutamate receptors, specifically the NMDA type. This opens up an ion channel that allows a pathological flood of excess calcium straight into the neuron. Now, this excess calcium is highly toxic because it triggers a destructive cascade that literally overexcites the cell to death, leading directly to apoptosis. Memantine steps in, acts like a bouncer, blocks that NMDA receptor, stops the toxic calcium entry, and completely halts the neuron from dying. This beautifully demonstrates how mastering this microscopic receptor stuff translates directly to protecting your patient's brain. I'm going to leave you with this final thought as you hit the books. Your future patients are relying on you to truly understand how their medications work at the cellular level. By mastering pharmacodynamics, you're equipping yourself with the exact knowledge you need to make life-saving clinical decisions. So keep studying hard, stay incredibly focused, and I promise you are going to dominate those exams.
I'll see you in the next Confused Neurons Explainer.